Hi, everyone. Welcome to ToniTime, where solutions are just a discussion away. Today, we're going to lean into the statistic around 72% of workplace violence in healthcare being verbal violence, and only 28% of that is actually physical. And so today, I'm going to ask you to open up your minds. Let's lean in with a little curiosity and explore the topic of a care partner or support person and the potential for this person to help decrease some of the verbal workplace abuse. I'm Toni Land, founder and chief experience officer for Landing Exceptional Experiences and your host of ToniTime. So I looked up some information from the Department of Health and Human Services, and you'll definitely see the links below so that you can research the document yourself. But there were several questions that were being asked, and one was around what constitutes patient visitation under CMS regulations. And so back in 2010, there was a federal law and some other regulations that required hospitals that receive federal funding, if they accept Medicare or Medicaid, that they had to allow patients and visitors the right to decide who could visit them. They were able to designate that. Before then, that wasn't the case. It was really limited to family only. And so these visitors could include a spouse, a domestic partner, a same-sex spouse or domestic partner, other family members, friends. Other examples were clergy, chaplains, ministers, faith leaders. And these facilities also had to ensure that their policies did not discriminate based on race, color, national origin, religion, sex, gender identity, sexual orientation, or disability. And the patient or resident also has the right to withdraw or deny consent to any such visitor at any time. In addition, individuals that have disabilities have a right to be accompanied by a support person in specific situations. So another question out there was, do facilities have to notify patients or residents of their right to patient visitation? And the answer is yes. All facilities must have a written or policy or procedure regarding the visitation rights of patients. And these policies and procedures include any clinically necessary or reasonable restriction or limitation that the organization may need to put into place. And they also have to state the reasons for that restriction or limitation. One more question from the Department of Health and Human Services that I thought would be interesting for this conversation is whether facilities are allowed to limit patient visitation. And the answer is yes, you are. Hospitals and critical access hospitals and long-term care facilities may limit access to their facilities so long as the restrictions are clinically necessary or otherwise reasonable. Now, one example that they give in this document is limiting visitation hours or the number of visitors at a time. So, that's an example that they give of clinically necessary or otherwise reasonable. Now, let me just set the record straight here. I'm not saying that visitors aren't important. I'm not saying that. But I do think we have an opportunity to definitely listen to the voices of our team members, see the high number there of verbal abuse and exchange that's occurring in our organizations, and look at how can we decrease the potential, so being proactive, decrease the potential for verbal workplace abuse. And maybe that's by decreasing visitors and focusing on care partners and support persons. Now, you might be wondering, why care partners and support persons? Like, what does that mean? Who is this person? And so the literature out there would tell us that this is a person that is identified by the patient themselves many times in advance of an admission to a hospital or a long-term care facility. And the main role of this person is to help their loved one heal through support and encouragement and communication during their stay. And so because of this role, they are considered a part of the patient's healthcare team. So some organizations might have the patient choose more than one support person. And one of the support people would be considered the primary support person. And that person is encouraged to stay with that patient 24 hours a day, if possible, or at least trade off with another support person. So 24 hours, that support person, care partner would be with this patient to be engaged in conversations about care for the patient. And so they are also the ones that would be communicating back to the family or community or that designated circle for, for that patient as appropriate. And so, what are some positives to this kind of shift? So, we see an increase in recovery times, a decrease length of stay. We also see a boost in morale for the patient themselves. There's comfort and relief and a reduction in anxiety. And we especially see a decrease in some of that delirium that can occur in intensive care settings. They often can help supplement some of the day-to-day care that's provided by, your hospital staff and your team members. They can also chime in on things that might go unnoticed if this patient were by themselves. So you look at this person, this identified care partner or support person, they are able to provide detailed information about the patient. And so I think of my mother-in-law and how she would be able to provide detailed information about my father-in-law when they were in the hospital that he sometimes could not provide himself. But she, as his primary caregiver, his care partner and support person, could provide that detailed information for the team to help improve and inform the plan of care. So we see smoother transitions and smoother communication. So a care partner versus a visitor who is just someone who has come to engage and show support to this patient, but not really involved in that care. When we see these care partners and support persons, then they're better equipped to help this patient once they're discharged, also, hence that impact on readmissions. Now, are there some cons? Yes, there are definitely some cons to visitation in general. Really, the cons point to visitors, whether that's a limited visitation policy or an open visitation policy, but definitely some cons there. And one of them was around information being transmitted that patients may not have wanted transmitted. There was a survey from an emergency department where 42% of the patients had come in with a relative. Although, when inquiring, less than half of them actually desired that their health information actually be shared with this relative or family member. So just because they came in with that person didn't mean that they considered that person to be their care partner or support person that they wanted their information shared with. So you can imagine in any of those cases when there's visitors in the room, so not an identified care partner or support person, then team members have to obtain some type of consent or at least verbal consent before they can share information in the presence of any visitors. So you think about HIPAA and making sure that we're respecting this patient's privacy in only sharing the information that they would want us to share. I will tell you that hospital staff and many of your nurses and techs feel like when you have a large number of visitors and open visitation policies, that it really hinders and impedes their ability to practice and increases their workloads. And so many times I've heard this before and I've experienced it before. You go in to perform a necessary procedure, and maybe you're with the tech also because it takes two people to do this work. And you're going into the room, there's several visitors present, not a support person and not necessarily a care partner, but visitors in the room. And then you have to ask them to step out, or you have to determine to do it at another time. So we're going to talk about work efficiencies and workflow because you have other patients that you're caring for also. So that can be a hindrance and a con around unlimited or open visitation type policies. Now, there is some literature out there that says that family members and visitors often demand a greater accountability from healthcare providers and team members. And so sometimes the team members feel threatened or targeted because they're being challenged by family members that are in the room. And we think back to that stat of 78% of verbal workplace violence or abuse. Many times that is coming from a visitor and not necessarily a support person or care partner. Finally, I looked at some literature and I thought, from families, and I thought it was summed up so nicely that the family perspective was summed up around this phrase: loved ones are not visitors in a patient's life. We are looking for transparent communication and patient empowerment so that we increase patient safety and improve the hospital experience for both the patients and their loved ones. When I looked at the Barrow Institute paper, We Are Not Visitors, they indicated that family caregivers are critical to positive and successful patient outcomes, and their caregiver experience is distinct. The caregiver, as the expert on the patient, is the key partner on the care team and plays a critical role in co-designing care for the patient. Caregivers, or you might even think care partners, support persons, caregivers frequently identify gaps in care and services that prevent patients from achieving their goals and functions, and they function as important voices in the decision-making process. So notice that none of them really talked about themselves as visitors. They talked about themselves as being that caregiver, care partner, support person to really come alongside this patient in order for them to have the best outcomes. And so when I look at going back to that stat, 72% of workplace violence in healthcare is verbal, while only 28% is physical. In the previous video, and I'll put the link below, Stop Yelling at Me, we know that many organizations have focused on the physical aspect of that. They have increased in security presence across the organization and in many settings. Many of these security professionals bear arms in order to protect the teams. There's signage up that talks about expected behaviors from visitors that are coming onto the premises. But that focus, a lot of that focus is on that physical aspect, but 72% is verbal. And so now we've got this opportunity to make this shift, that a shift that can positively impact patient outcomes, teamwork efficiency, and team safety. So we can intentionally designate this primary support person or the support team or the care partner team so that we can now educate and empower them on their role. And so this is an intentional shift in the organization. Now, how does this all start? I think you know where I'm going to go with this. Co-create, co-create, co-create. So you've got to get patients, family members themselves, team members themselves, all in a room, looking at the literature, looking at what this escalation of verbal abuse, incivility looks like in your organization, and then have them to start talking about how we make this shift to not so much around visitors, and maybe even limiting that some. The co-creation group can decide that, limiting that some, and really focusing on this caregiver, care partner, support person who can really come alongside to improve outcomes and see this decrease in verbal escalation. Because we think that some of this verbal escalation is stemming from fear and loss of control. So this co-creation team can talk about, what does education and empowerment look like? So we decrease the care partner and support person's fear and really encourage and enable them and empower them to be able to assist as part of the care team. And so we want to educate, empower, and help them to understand how do they effectively engage with the team. Now, I'll tell you one thing that I have not seen is something that explains to the family caregiver, the care partner, the support person, what is considered acceptable, effective communication. And I think that is so important because if we don't set that standard around what does this really look like, sound like, and feel like, then we're leaving it open for interpretation. And so I think the team can decide what is acceptable, effective communication. And I think providing them with the resources. So if they're being admitted to the hospital, then on orientation to the room, we would verbally share who the chosen or selected primary person or primary support person or care team is, and talk about here's what that looks like. Here's how you support, here's how you engage as part of the care team, and here's what acceptable, effective communication looks like. And I will also say, we want to share with them what acceptable, effective communication does not look like. So what's unacceptable, ineffective communication. So we're very clear on what communication looks like in our organization, on our various units, in our various departments. If you're in a long-term care facility, same thing. When they're coming into your organization, you would set that same standard. And this co-creating team would be part of really designing, what that looks like and what this, I'm going to call it circle of communication, this circle of acceptable, effective communication looks like. Now, in my ideal world, we would also have videos that they can watch that show them here's what acceptable, effective communication looks like. Here's what unacceptable, ineffective communication looks like. So we are very clear in setting these standards. Now, this team will also want to decide what happens when the support person, care partner, is not following through on what has been deemed acceptable, effective communication. How do we escalate that? What is that level of engagement around revisiting what we shared with them on admission to our organization and the next step? So that's all part of this co-creating, and it is part of the policy that you are putting in place. And so now what can you expect? What are your expected outcomes around this work? Well, as we've talked about, the literature would tell us that we can expect to see a decrease in readmissions. These care partners and support persons are engaged in the patient's care and able to better help them once they go home. We'll see a decrease in the length of stay. We've even seen an increase in medication adherence in some of the literature. And so now I'm looking forward to really hearing from you. What's going on in your organization? Do you have some way of truly designating a care partner, a support person? What's your thoughts around should we have less visitors and really focus and intentional around this care partner or support person or team? I'm looking forward to hearing from you because I think this can be a huge shift for healthcare organizations and help the teams to know that we are listening to them and we are looking for a way to provide not just physical safety for them, but verbal safety for them also. So ToniTime is brought to you by Landing Exceptional Experiences. Landing Exceptional Experiences partners with healthcare organizations to improve patient experience outcomes and Leapfrog Hospital Safety Grades. You're going to find a link below for your 30-minute consultation. Click that, and I look forward to talking to you. Finally, don't forget to not only comment, but to like, subscribe, and share this video. This has been ToniTime, where solutions are just a discussion away.